And I will officially welcome you all to our academic update for the UNT Retiree Association. I think they're all UNTRA members with us now, but we might have a couple of OLLI members joining us as well. So we certainly welcome them to this special presentation. And it's going to be led primarily by Dr. Ateka Contractor, who is an assistant professor in the Department of Psychology. She earned her PhD from the University of Toledo. She did her postdoc in the VA Boston Healthcare System and Massachusetts Veterans Epidemiology Research and Information Center. And she's going to be talking to us today, of course, about the Stress Lab, which is the study of traumatic experiences, signs, and symptoms. So, and as I mentioned, this is going to be a little bit interactive, so feel free to mute and unmute yourself. And if there's any noise in the background, of course, we ask that you go ahead and mute yourself until that passes, but feel free to interact. So without further ado, I'll get out of the way, and Dr. Contractor, the floor is yours.
Thank you. So hello, everyone. Y'all can hear me okay? Let me first check on that. Okay, awesome. So a couple of caveats. I've tried to keep my kids away, but in case they pop into the screen at some point, just saying, FYI. And then the second thing is, like, if Zoom, there's some malfunction on share screening, just bear with me. We're going to try a few new things this time for the presentation. Okay, so my name's Ateka. I am an assistant professor in the Department of Psychology. I primarily research trauma and post-traumatic stress disorder, and that's what we're going to be talking about today. But before I share my screen and start the presentation, I want to give a chance to Sidonia to introduce herself, who's going to be co-presenting with me.
Hi, everyone. My name is Sidonia. I am a first-year student in the clinical psychology program, and Dr. Contractor is my mentor. I've been in Denton, I guess, since August, and I'm really excited to be here. I'm excited about UNT, and I really enjoy researching PTSD and trauma with Dr. Contractor.
All right, I will try to share my screen and start the presentation. Okay, can y'all see the presentation okay? Okay, awesome. All right, first try successful. Okay, so as I said, we're going to be talking about trauma and post-traumatic stress disorder today. We're going to give a little bit of an overview of what we do in the stress lab. I'll talk a little bit about the assessment piece and then the intervention piece, which will also tie into how we cope with stressors in day-to-day life. Okay, so I thought that, oops. All right, there we go. Let's see. Oh, there we go. Okay, so I thought that before I begin, I just want to say what's the ultimate aim of our research program here in the Stress Lab. So what we really try to do is help refine the diagnostic algorithm for PTSD. So we have certain symptom criteria we follow in our clinical practice. Is that good? Is that accurate? Is that valid? Is that reliable? Okay, so we do a lot of work on the assessment front of that. And then the other thing we're hoping is that our research will add to individualized and culturally informed trauma treatments. So we'll talk a little bit about how our research actually gets into the area of PTSD treatment. So my research here in this lab has three legs, basically. We look at PTSD symptom and trauma heterogeneity. We look at PTSD's co-occurrence with depression and engagement in reckless or risky behaviors. And then we look at cultural influences on PTSD symptoms. So at least for today, we're going to be focusing on the first two to make it a little bit more relevant. So we'll start with PTSD and symptom and trauma heterogeneity. But before I get into a lot of those details, okay, we know from statistics and evidence over here that 90% of individuals from the US report an experience of at least one traumatic event in their lifetime. That's a significant number, right? But I just thought it'll be helpful to know what y'all think about trauma. Okay, so this is where, let's see, I've done this for the first time. Let me end show. And let's see if this will function as I thought it should. Okay, can you all see the new screen? Okay, so if y'all can go to menti.com and just enter this code in. And then it will just ask you to describe the word trauma in one word. So I'm curious to know what y'all think about trauma. Just one word. Let's see if this will work as I thought it should. Okay, why is this not showing up? Have you all entered? Oh, there we go. Okay. I think you can do like multiple tries too, since we are fewer people. So if you have any more words. I think it's probably, there we go. Okay. Anything else that anyone wants to add? I don't know if all your responses are showing up yet.
How do we do this? I can do it on my phone.
Yeah, the phone might work. Yeah, I was able to just go to menti.com, and then the first thing it asks for is the code, which is
Right.
2303132. And then
And I got that.
And then it popped up with some fields to just say enter the words that come to mind. It gives you three fields, and then below that is a blue submit button.
Did you get that? Is it working for you?
I have 3 on my phone.
Okay.
Yeah, you should be able to type in words into those, and then you should see like a blue submit button.
Right.
And once you enter those in and hit the submit button, I think they'll show up.
But not on the screen.
Not on your screen. I think it should show up on Dr. Contractor's.
I see.
Do you see your responses that you've entered on the screen?
Now
I see
do.
mine. Mm-hmm.
Okay, awesome. Okay. Yeah, let's wait for just a couple more seconds to see if there's anything else. So basically the one that's been entered the most amount of times shows up as in the center and the biggest one. Yeah, okay, so a few more responses are coming in. Any thoughts on the answers you'll see?
So I'm kind of surprised that head and brain is smaller, but I'm not surprised by stress, death, and loss.
You know, a lot of times when people think about trauma, they think about like a traumatic brain injury sometimes. And that's when, I think that's probably where that comes in. Concussion, yeah. So all the physical injury traumas, and then we have the psychological injury, or the psychological traumas, and that's what the death, the loss, the stress, violent. A lot of the times people do think about it in the context of military. That's probably why it's showing up. We do a lot of research with military active and veterans in our lab. Okay. Any other thoughts before we move along? Because this was super helpful to see how you'll conceptualize the word trauma. Okay. All right. Now this is going to be a challenge. Let's see if I can get back to my PowerPoint. Oh, I stopped share. I shouldn't have done that. Let's see, where is my, okay. Okay, so these are the kinds of conceptualizations that you all provided, right? we in clinical practice, I will tell you how a trauma is defined. So if you go to like a psychologist or a mental health provider, we follow certain definitions listed in our book that we use to diagnose individuals. So in that book, it said it's an exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So you directly experience something, you witness something that's happening to someone else, you learn that it has happened to someone else, and usually this is a close person, okay? And there are some other caveats to that. Or you experience some of those traumatic events as a part of your job. So if you think of first responders and you think about people in service, okay, that's where you think that they have a high likelihood of experiencing what we would call as trauma in clinical practice, okay? So in our lab, we look at a few aspects of trauma. So the first thing I want to talk about is just briefly about types of trauma, because not all traumas are equal. There are different types of traumatic experiences. And in our research, which is consistent with a lot of the research existing out there, interpersonal trauma, so traumas that are perpetrated by another individual. So when you think about abuse, neglect, all of those kinds of situations, okay, they have more detrimental impacts. So their impacts are worse than, say, non-interpersonal traumas. That's like a natural disaster or a motor vehicle accident. Just broad comparisons, okay? The other thing, what we do in our lab is look at how many traumas does a person have, and if that impacts psychological or health outcomes. Okay, so we have two existing theories in the literature. One says that the more traumas you have, it's actually building resilience because it's giving you some way to practice coping. Okay, so you become resilient over a period of time. The other viewpoint says that no, the more amount of traumas you have, your health is actually deteriorating. So your functioning declines. Okay, so our lab was like, maybe there's a certain threshold. Like up till a certain number of traumas, you function okay, you're resilient, but after a certain number, your functioning kind of goes down. Okay, so we found a range, again, the kinds of samples we looked at was so diverse. I looked at a sample from the US and then a sample from India. And so, bearing all of those, differences in mind, we have like 3 or 10 trauma types. If you exceed that range, your functioning drops off. Okay, so it kind of declines. So in a sense, our lab says the type of trauma matters and the number of traumas you've experienced matters in terms of determining your functioning. Does that make sense? I don't know if y'all have any questions so far. Okay. All right, so that's one aspect. Now, one more interactive piece, okay? So we will again go to menti.com if I can do this right. And y'all are going to describe the word post-traumatic stress disorder, okay, in just one word. So let's see if I can do that. Okay, can you all see the screen? Okay, so just the same protocol, it's probably the same code. It is the same code. And now just describe post-traumatic stress disorder in one word, whatever you'll think it is. Okay, getting more. Very critical word, trigger. I use that with my, clients for therapy all the time. If you don't mind me asking, who said continuing? And it could explain a little bit more. Yeah, can you say what you mean by that? I'm just curious.
Well, it's partly just from people I've known that have had post-traumatic stress disorder. They continue to be stressed. They continue to have a high level of anxiety and continuing fear and recurrent nightmares, and they can't get past their memories. So it's all those other things and triggers, are part of it. But the stress from the trauma just doesn't leave them. That's what I had in mind.
Yeah, no, very well said. Yeah, thank you. Thank you for sharing that.
Mm-hmm.
Anyone else have any other comments on what's so far on there? Because if all of this is accurate, yeah.
There's a word I can't think of when I knew someone in Vietnam, for instance, who had PTSD, and it was when you keep reliving those memories. What is that called?
Flashbacks?
Thank you. That's it. Flashbacks.
Very, very, very common symptom that we see amongst people with PTSD. Okay. There we go. Okay. Yeah. Yep. All of this, like when I go to the next slide, you'll see that all of this actually fit in with how we clinically define PTSD. Okay. All right. Let's see how. Okay. Okay. All right. Oh, all right. There we go. Okay. So in clinical terms, now I'll tell you what PTSD means for, a mental health provider. And you'll see a lot of the things that you've mentioned actually fit in very nicely with the diagnostic criteria. So actually, before I begin, we have certain groupings of symptoms, okay, in PTSD. So I'll talk through the terminology is not important, but just understanding what those groupings are will actually be helpful. So one of the groupings are intrusion symptoms, okay? So these are symptoms like we talked about flashbacks, okay? Another big intrusion symptom is you have these intrusive thoughts and memories just like that, okay? They just pop in and you don't know where they came from. Sometimes it's with a trigger, sometimes it's without. Nightmares are another big one that a lot of people talk about. Okay, so we have these intrusion symptoms there are 5 in that category. The other big one is you will hear individuals with PTSD say, I avoid thinking about it. I avoid talking about it. I avoid visiting a place or seeing things that remind me or people that remind me of the traumatic event. So avoidance is also a very critical feature of the PTSD diagnostic criteria. A lot of people argue this is what maintains PTSD because they get good at avoiding. Okay. And I tell you, like I've seen, military service members from Vietnam come after 30, 40 years for the first time in treatment. And a lot of the patterns I see is I asked them, I said, so why now? They're like, well, I've retired and now I don't have all those avoidance coping strategies that I used for so long to keep my symptoms at bay. And so now I have nothing to do and things have come up and I cannot handle them. So this is very common that I've seen in my clinical work. Okay, so avoidance really helps to maintain those symptoms. We have another one that's called mood and cognitions, which is basically how we think and how we feel. So a lot of the times individuals with PTSD, they'll watch a funny movie, but they're like, I cannot get myself to laugh at it. They don't enjoy being with people. They cannot feel any positive emotions. They feel a lot of guilt, a lot of shame that's not needed. Okay. So we have all of those symptoms that come in. There are like 7 or 8. I cannot remember exactly. And then we have arousal symptoms, which is the last clustering. Okay. And these are things where hypervigilance, startle responses. So I've had clients who will tell me they cannot sit with their back to the door at a restaurant. They want to be able to sit right at the back where they can see everything that's happening, or even a small noise, and especially like 4th of July is hard for individuals. Small noise will trigger, these startle reactions that, are way out of proportion for what it's supposed to be. Okay. People cannot sleep. They cannot concentrate. Okay. They get very angry. They engage in behaviors they consider extremely reckless. Okay, so self-destructive. So a lot of those symptoms come under the arousal grouping of PTSD. Okay. Now, as a practitioner, we also want to make sure the symptoms last for more than a month and it's actually impairing to the individual. Okay, because otherwise you'd really, you have symptoms, but if it's not impairing to you, there's really no diagnosis there. Okay. So a lot of the research we do in the stress lab focuses on these groupings of symptoms. And I'll tell you in a minute why this is important. Okay, let's talk about an example first. So we have these 2 individuals. They just meet up like based on what I've seen. We have somebody who says the traumatic event is having killed somebody in war. There's another person who said, I've had a motor vehicle accident. That's my traumatic event. And all I've done is I've listed the symptoms, okay, that they are telling me they've had. So the person, male, saying, I have nightmares. I avoid thoughts that trigger these memories. I don't think good about myself at all. I blame myself a lot for what has happened. Like, why did I kill this person? How can I ever get over that? Okay. There's no interest in doing things that they used to enjoy. They don't like to be around people. They're very hyper vigilant, they have temper tantrums, okay, aggressive outburst. The other one says, I'm reacting emotionally to cues. I have flashbacks. There is a lot of, even like having trauma reminders has physiological arousal symptoms. They avoid places, so probably the place they may have gotten into an accident, okay? Isolating from people, cannot remember the traumatic event. And that's pretty common. What people will come in and say, I don't remember much. I can tell you the skeleton version of it, but that's it. Concentration difficulties, sleep difficulties, and startle responses. Now, both these people would get diagnosed with PTSD, but you see how different they are? So as a person who knows somebody with PTSD or a person who's providing treatment, we have to be aware that the presentation of PTSD is quite heterogeneous. Like, we cannot assume that because people are diagnosed with PTSD, they have the exact same trauma and the exact same presentation. And this is very, very important because we want to know, are these symptom groupings accurate? And also, so we have 4 right now, okay, that in the book we follow. Are they accurate? And are the number of symptoms in each of those groupings accurate? Because they influence who gets diagnosed with PTSD. That influences who gets treatment and what kind of treatment, right? Also, how many individuals have a clinical level of PTSD has policy implications. Funding goes through its research, or in the VA, they get disability claims. All of these things have like more downstream impacts. But we have to start with the basic. Is the diagnostic criteria for PTSD what it's supposed to be? Is it solid? Is it reliable? Is it valid? Okay, we talk about these symptoms, but are they accurate? Like, do they accurately represent PTSD? So I'm going to show you one very boring slide, but hopefully I can drive the point across. Okay, so just bear with me here. So we have these 4 groupings that I just talked to you about. Okay, and I said we focus on these 4. So let me tell you how these groupings are under debate at the moment. Okay, this is the boring slide, but hopefully I can get the point across here. So you see right now, B1 to E6 are all the symptoms of PTSD. We have 20. And what you see in the first column right now, which is called INT, avoid, NACM, AAR, are just the 4 groupings I showed you. But a lot of researchers are saying these 4 groupings are not accurate. Actually, there's one grouping that should be different. It should have different set of symptoms. Okay, so one set of researchers are saying we have 4 groupings, but that's not accurate. The groupings need to be reorganized. But then another group says, well, we don't have 4, we have 5 groupings. And they split up the last one into 2 more. Okay, all right, we don't stop here. There are 2 other people, groups of researchers who say, no, it's not 4, or the nature is not different, or it's not 5, it's 6 groupings. But look, they're drastically different. So if you don't focus on all those acronyms here, you just see how they're all constructed differently. And then more recently, they're like, well, there are 7 groupings. So as a practitioner, I'm supposed to assess for 7 groupings of symptoms, which influences who gets diagnosed with PTSD or clinical levels of PTSD. So a lot of my research has actually found support for that 7 grouping model, which is not the one that's used in current practice. Okay, so there is a lot of work to be done. Okay, so we don't want the research and clinical practice gap to get wider. We want that to translate into practice. Okay, so this whole segment was just on how to assess PTSD accurately. Okay, so it was all about the assessment of PTSD. Now we'll move a little bit towards treatment. That's where I'm going to talk about the second one with co-occurrence with depression and reckless behaviors, but we'll focus on just general treatment of PTSD first, that Sidonia is going to take over. And then I'll come back and talk about what we are doing in the stress lab with positive memories as a potentially novel treatment for PTSD. Okay. Any questions? Let me pause here for a second. Any questions so far? Okay, Sidonia, all yours. You
can go ahead and get to the next slide. All right. So we've talked a lot about different symptoms. What does PTSD look like? How it can look different among people. But we haven't really talked about like, how do we treat this? How do we address this? The American Psychological Association has identified 3 strongly recommended treatments for PTSD. They're cognitive behavioral therapy, cognitive processing therapy, and prolonged exposure therapy. So all of these are kind of based on the cognitive model, which is that our thoughts, feelings, and behaviors are related, and all of these things interact. So these different therapies kind of work to target the different areas of your thoughts, different areas of behaviors, different areas of your feelings. So cognitive behavioral therapy focuses on restructuring thoughts and changing behaviors, while cognitive processing therapy discusses or works on evaluating and modifying these unhelpful thoughts and the beliefs associated with the traumatic events. And prolonged exposure therapy actually exposes a person to the traumatic event or the things that they're afraid of, these triggers that we've talked about, to help them reduce their, arousal and reactions to them. Because cognitive behavioral therapy is kind of embedded in cognitive processing therapy and prolonged exposure therapy, I'm just going to talk about the cognitive processing therapy and prolonged exposure therapy in the next 2 slides. Okay, so cognitive processing therapy is a form of cognitive behavioral therapy, and it can occur in about 12 sessions. It can be done individually and it can be done in groups as well. So they will actually put people together to kind of work on addressing these thoughts together and share their experiences. It focuses on challenging and modifying unhelpful beliefs related to the trauma. So often people who've experienced traumatic events will think negative things about themselves, think negative things about the world, about others. They may feel the world is dangerous, and these beliefs may be even amplified because of their traumatic experience. So cognitive processing therapy focuses on safety, trust, power, control, esteem, and intimacy so that these people can function better in their lives. And we have a little video here that we can show you to tell you just a little bit more about it.
And Dr. Contractor, is there sound to this?
You're muted, so that's probably why it's not.
When you might need to do the screen share again, because there's a checkbox when you share your screen that allows you to share the sound.
Oh, hold on.
These kinds of thoughts are common.
Okay.
I hear it now.
Yeah, we actually could hear it
Soft.
there for a second, but when you hit the share screen button at the bottom, there should be a checkbox that says something like share computer sound.
Okay, let me try that again.
Think about yourself and the world. You might think you're to blame for what happened or believe you don't.
Can you hear that?
I think we're maybe just hearing it through your microphone, so it's kind of low.
Okay, so what do I do when I?
Well, when you start at the very beginning of that share screen process and you hit the green share screen button, there should be, like I said, a checkbox maybe on the bottom left.
Okay, let
And
me try that again.
it should say something like share sound or share computer sound.
Okay, let me.
So it'll be that same screen where you choose which desktop you're sharing at the
Oh,
bottom
I
of
see.
that.
Oh, share sound.
Yes, that'll do
Okay,
it.
all right. Sorry about that.
No problem.
Deserve to be happy. You may start to believe the world is unsafe. Doing things like going to a grocery store or restaurant may seem too dangerous. These kinds of thoughts are common in people with post-traumatic stress disorder or PTSD. They're called stuck points. They keep you stuck in your PTSD and cause you to miss out on the people, places, or activities you used to enjoy. So how do you get unstuck? Cognitive processing therapy, or CPT, is a PTSD treatment that can help you break the negative thinking that's holding you back. It's based on the idea that our thoughts affect how we feel and how we act. In CPT, you and your therapist will talk about how your negative thoughts about the trauma, those stuck points, have changed you, how safe and in control you feel, how much you trust yourself and others, and even your sense of self-worth. You'll practice a strategy to change or challenge your stuck points. PTSD can make you jump to negative conclusions, but there may be other ways to think about things that are more accurate and less upsetting. Imagine you're driving down the highway and someone swerves in front of you. You might blow up at the driver. What a jerk. But what if he was racing to the hospital or having a panic attack and rushing to get off the road? If you considered these possibilities, you might not feel as angry. The bottom line, small changes in thinking can have a big impact on how you feel. Some people find that writing about their trauma helps them change upsetting thoughts and feelings. You and your therapist can decide whether or not this is right for you. CPT works just as well either way. You can also choose to meet with your therapist one-on-one or in a group with others who have PTSD. CPT is evidence-based, meaning it's been shown to work in multiple research studies. And it doesn't take years. In fact, CPT usually takes about 3 months of weekly visits. CPT can help you get unstuck, freeing you up to start enjoying the things you've been missing out on. Men and women, veterans and civilians can all benefit from CPT. If cognitive processing therapy sounds like it could be right for you,
I'll stop here because the last piece is just very relevant to the VA, but let me try to get back to the PowerPoint.
talk to your doctor.
Okay, so that was a quick little summary of cognitive processing therapy, challenging those stuck points related to traumatic events. Another cool therapy that's evidence-based is prolonged exposure therapy, which is also a form of cognitive behavioral therapy, addressing those thoughts and those feelings and behaviors. It can occur in about 8 to 15 weeks in sessions that are 60 to 120 minutes long, depending on the nature of the session. And it includes gradual exposure, which basically means we expose the client or the patient to something that they're afraid of, something that their traumatic event has made them afraid of, or triggers them or startles them and has some sort of reaction to. Because when people with PTSD are exposed to these things, they're likely to feel very overwhelmed. They might have panic-like symptoms. Their thoughts might get negative. So they avoid these things. And then we've learned that the more we avoid these things, the stronger these reactions get, because we kind of reinforce these reactions. So as uncomfortable as it sounds, an effective treatment for PTSD is exposing yourself to these things that you're afraid of, exposing yourself to the hard things, the reminders of the events. So whether it's walking by a certain place that reminds you of the event, or something else that reminds you of the event, like a certain smell, exposing yourself to these things and teaching your body to calm down can be incredibly helpful. We can use imaginal exposure, which is just imagining the different events that trigger you or upset you, or we can use in vivo exposure, which is actually like going to locations or bringing in things into the therapy room to expose yourself to. So basically you're teaching your body not to have these reactions, that you are in a safe place and that things are okay. And then we have a clip here as well that kind of explains a little bit further.
If you have post-traumatic stress disorder or PTSD, it's common to feel like there are places or situations that are unsafe. It may seem like the best option is to avoid them, staying away from people or places that feel dangerous or reminders of a traumatic event. As a result, you may develop I can't rules. I can't leave the house at night. I can't trust anyone. I can't handle crowds. But these rules won't help you overcome PTSD. So how do you learn to say I can? Prolonged exposure, or PE, is a treatment for PTSD that helps you do safe things you've been avoiding. In PE, you and your therapist will practice exposure, meaning you'll work to approach things you've steered clear of since the event. You have to challenge your I can't rules to prove to yourself that you can. Remember when you were learning to swim or even drive a car? It was challenging at first, but got easier with practice. Exposure gets easier with time. With your therapist, you'll take steps to do the things that have been hard for you at your own pace. So if you're avoiding the grocery store, you might start by going when it isn't crowded, maybe bringing a family member along. You'll eventually practice going on your own, perhaps even during peak hours. With practice, you'll find that you can handle it. You'll also talk through the details of your traumatic event in a safe, gradual way with your therapist. Closing your eyes can help you concentrate. Retelling the event may sound like the last thing you want to do, but it helps with emotions like anger, guilt, and sadness. You'll listen to a recorded version at home too. After a few months, you'll find that you can talk about your trauma without feeling so overwhelmed. Prolonged exposure doesn't erase your trauma, but it can help you keep your traumatic experience from getting in the way of living your life. PE doesn't require you to take any medications. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who complete PE show noticeable improvement in their symptoms, and many no longer have PTSD. Prolonged exposure works well for both men and women, and it's evidence-based, which means PE has been proven to work in multiple research studies. If prolonged exposure sounds like it could be right for you, talk to your doctor about finding a PE provider, or visit the National Center for PTSD website at www.ptsd.va.gov to learn more about PE and other PTSD.
So that just explained prolonged exposure therapy a little bit more. Also interesting to note, exposure therapy also can be helpful for anxiety disorders as well, because there's similar processes involved. And this can also be used for like when people have intrusive thoughts, like those flashbacks or random thoughts popping up in their head, teaching their bodies to kind of calm down in those moments. So translating the skills of like, say, deep breathing or mindfulness into the moments of panic and when there's no like explained trigger as well. Does anyone have any questions about these two treatments? It's fine if you don't. But these are evidence-based. The American Psychological Association supports them and very recommended for PTSD treatment. But we all know that something is going on right now that's incredibly stressful and hard on us. That's the COVID-19 pandemic, plus everything else that's been going on in the world in the last year. It's been quite a year. And we do want to highlight that it's normal to kind of feel this stress and anxiety during this time. we're humans. We have reactions to things. We're allowed to have thoughts and feelings, even if they're not positive all the time. So on that note, have y'all done anything to kind of cope with the pandemic stress and the changes that's been like helpful for you?
Well, I'll say that I've found taking walks around the neighborhood to be helpful. It was something that I did not as often before, and especially on a day like today, if I do it long enough, it usually gives me time for my minds to kind of let go and stop focusing on whatever I have to do for work or anything like that. Just kind of get those blank moments.
Yeah, for sure. Sometimes
I have a friend, and that's what we've been doing in the neighborhood every day,
it's
going for walks.
very good. I think we've had to kind of be creative with things.
I got
ahead.
married.
Yes.
got
Congratulations. Right? It works. Congratulations.
Ask him. He's on here too.
Nice.
They got social interaction by getting married.
Yes, that's one way to
The
bring
rest
it.
of us are having to Zoom, but that's a good way to go as well.
Yeah, we've all had to learn to advance our technological skills and figure this all out. But yeah,
Lots of Zooming.
yes. We're doing grad school over Zoom, so I actually haven't seen Dr. Contractor in person since I interviewed last year. Crazy times. But yeah, there's different strategies and things we can do to kind of be creative and take a step away from like all the stress right now. So whether that's reading, about positive things, not necessarily the news, but reading a good book or taking a walk, practicing some mindfulness strategies like taking deep breaths, eating healthier, exercising, trying to connect with other people.
Eating healthier has happened. It's probably been worse, but
It's we pick and choose which things work for us. Some things are good coping skills for us and some things aren't. It just depends. But just taking those times for you. We have to practice self-care, especially during stressful times. And whether that's eating an apple or Hershey's bar, taking a walk with a friend, or Zooming with someone you haven't seen in a while. Do what you need to do.
I had something that was really neat for our family. Can you hear me?
Yeah.
Okay. We had each person in the family, we have a large family. We have 5 grandkids and 4 adult children. But anyway, every week we would meet, the parents were having challenges with the grandkids, but we would meet every week, and a different a person in the family would do a kind of a teaching lesson. Like our son that's an artist taught art lessons, and that's just an example. And I think Don taught the elements. My husband taught them the element. But anyway, then at the end of it, they started a book club, the grandkids did, with each other. But anyway, that was kind of a neat kind of thing to find out what your own kids know that maybe you didn't know. And also the grandkids were intrigued with the other aunts and uncles and grandpa and grandma. So anyway, that was a good idea.
neat.
I love that. It's cool that we've been able to kind of introduce these different things.
Yeah.
And one of the things that y'all may not have noticed is in the PTSD treatments that I talked about, I focused on so much talking about negative thoughts, negative feelings, and negative emotions. So Dr. Contractor has a really cool research area on positive memories associated with PTSD. So I will let her take that away.
Yeah, before I begin with this, I was going to say that I'm e-schooling my elementary, age daughter. And so I'm definitely learning, I don't know, relearning school, I don't know, whatever you want to call that. So it's very different. And then you switch to teaching statistics to grad students. It's a different field there. Okay. So I think this is the last part of the presentation. So we're almost there. What I just wanted to highlight is in our lab, we also do research that's relevant to interventions for PTSD. So a lot of the treatments so far that, Sidonia rightfully just mentioned have focuses on trauma memories and traumatic thoughts and feelings and negative feelings, negative ways of thinking. But we know from the literature that positive memories and processes related to that, like how do we retrieve, how do we store, how do we consolidate those memories, they play a role in development of PTSD and also maintaining PTSD over time. And individuals with PTSD symptoms I've seen that in clinical practice, I've seen that in my research, they have difficulty accessing those positive memories from their lifetime, okay? And despite all of this research, our clinical work primarily targets traumatic memories, okay? But those treatments don't work for everyone. And there's another problem is a lot of people drop out of those treatments because can you imagine going to treatment where they're saying, now I'm going to tell you to talk about a traumatic memory for 30 minutes. It's very hard for people to do that. It's almost like they fear that. It's very effective if they can do it, but the fact of getting them in the door and having to do that for 30 minutes is hard as a therapist, okay? So we're trying to change a little bit of that and just add to the clinician toolbox is what we're doing. So in this regard, we pulled a lot of research, okay, from experimental psychology, which basically states that if you focus on positive memories, it can help you think better, it can help you feel better. We pulled from intervention research, so positive psychology and memory-based interventions. So from positive psychology, we have research that says if you write about positive experiences, you share positive experiences, you imagine positive experiences, it helps you feel better. And we also have other research saying that if you can improve someone's ability to retrieve memories, it actually helps with PTSD and depression symptoms. So we took all of this literature together and created a model that I'm just going to explain like the basic components of it over here. So just bear with me. But the idea is you focus on positive memories and that helps to reduce PTSD symptoms. Okay, and it happens through a multiple of ways according to this model. So one is that if you focus on positive memories, you get positive feelings, less negative feelings, you think better about yourself and other people, and you're also able to retrieve other positive memories. So that helps to reduce PTSD symptoms. But also what it does is it gives you practice in detailing your positive memories that may actually help you with those traumatic memories in the other treatments that you may pursue. Okay, so ultimately, if you can engage in those other treatments, the trauma-focused treatments, you won't drop out because now you have those skills in place. Okay, that's just a hypothesis. And therefore, you can also process those traumatic memories and actually get the benefits of that treatment. So there are a few components to this model. What we did now, we took this model and we developed our treatment technique that I and all our students, the whole team is piloting at the UNT Psychology Clinic, if you all are aware of that. So we've collected, it's a 5-session protocol. We ask people to come in. I'm just going to say what we do. We ask people to come in. In the first session, we just give them information about the treatment and why we do what we do. But sessions 2 to 4, we ask them to retrieve one salient positive memory and talk about it in a lot of detail. Like, what do you see? Who are you with? What are you thinking at that point? What are you feeling? What are some important values, thoughts, trends that memory elicits? So we ask them to process those memories in detail, okay? And then we do a review of symptoms and progress in session 5. So because of COVID-19, our enrollment has been very difficult for this. We would have been done by now, but we have data from 5 people who we piloted this on, and we see that they've reported less PTSD severity and less negative feelings over 5 sessions. And also they report more positive feelings, better rapport with their therapist, what we would hope for. And also they feel more ready to start those interventions that focus on traumatic memories. So we're seeing effects in the expected direction. It's 5 people and hopefully we'll get more. And then maybe we'll get a grant and do this on a larger scale. Some other interesting information, we've done experimental studies that actually show similar trends. Again, this was done at UNT using the psychology subject pool. And we found that if you write or narrate positive memories, you report less PTSD severity, less negative feelings, less negative thoughts, and better positive feelings, okay, over time. We did that across 2 sessions. Also, we queried clinicians and clients, and we asked them to give us feedback on this intervention. And we found that they actually have interest in discussing positive memories in session more in depth and frequently. And they think that if you do that, it will help to have more positive thoughts and feelings, okay? And they say, you know, it's easy to learn. It's not a hard technique to learn. And it may actually help make therapy more tolerable, okay? And we may get more satisfaction. So we have some feasibility data for this intervention. So there's a lot of work to be done in this area. But I also want to end with, you know, critically evaluating this, because that's what we do, you know, as researchers, we critically evaluate our own work. So I have found in some of the research that positive memories, when you narrate them or you access them, is beneficial. But that's not the case with everyone. I have a paper under review and paper that's published that says that if you access emotional positive memories, or sometimes you're sharing details with people about those positive memories, it relates to engagement in more reckless behaviors and alcohol use. Okay, so these are just, it's a skeleton overview. So we are like, okay, why is it working for some people and why is it not going to work for some people? So that's a question that we're still investigating. And I want to end with one hypothesis I have. So in regular life, if we retrieve positive memories, we feel better. But for people with PTSD, that may not be the case. So one of the symptoms I talked about is people with PTSD cannot really experience positive feelings. But for people who do experience positive feelings, they're not accepting of them. So I've had so many veterans who come in for therapy and say, I feel happy, but I don't deserve to be happy. You know, how can I feel like this? You know, I stood there watching my friend die and I couldn't do anything. Like, the guilt is too much, right? So for some reason, even if they can experience positive feelings, they can't stick with it. And then they will do something to, you know, in the hopes it will help to regulate. And that may be drinking alcohol, engaging in some reckless behaviors, things like that. So that's an area we're really doing a lot of work on. A lot of studies are in our stress lab are trying to figure this out, whether the affect, you know, the affect trajectories following positive memory retrieval are different and how that ties into different outcomes. Okay, so broadly, we've covered a little bit of assessment and we've covered some key points on treatment. I try to keep it consistent with what we're doing in the stress lab, but I think that's it. So we can take questions. I can stop sharing the screen easier, but we can take questions or comments or anything.
How do you recruit your the people to your lab for your study?
The participants, you mean?
Mm-hmm.
So we have different, depending on the study. So the study that's going on in the UNT psychology clinic right now, it's people who call in for assessments or for therapy. So that's that one sample that we're targeting because we wanted to make sure that they're actually wanting services. For other studies, sometimes it's through extra credit assignments, you know, that the instructors provide. But we've done a lot of community recruitment. We've gone to cultural events. We sat there with a tablet and we've asked people to come in and fill questionnaires, or we've done online, like Amazon's mTurk recruitment, where we'll pay participants to complete surveys. So again, depends on the design of the study. We've been pretty creative and I would say strategic and thoughtful about who we'll want to recruit. If that answers your question.
So when do you anticipate going back? Is there any way to know how long it'll be before you can go back to in-person?
I mean, I think we are supposed to go back in the fall. That's my guess. but we know how it's a moving target. So I'm hoping sooner than later for everyone's sake.
Could I recommend somebody to your study
Yes,
privately?
sure.
I know someone who could probably benefit a lot if you're
Okay.
taking his case. I will do that.
Okay.
I will ask him first. I will ask him first, but
Okay, sure. And you have my email, and if we need to talk, we can talk as well. They'll just have
Okay.
to go through the psychology clinic. But yeah,
Okay.
thank you. Yeah.
What about fees? Are there charges for services?
At the psychology clinic
Yes.
in Sidonia, you may be able to speak a little bit more because I'm not currently supervising students in the doctoral program, like for clinical supervision. I'm just running the study. So for this study, we actually are paying participants to come in because we are piloting this treatment. But I think there are fees, and it's on a sliding scale fee. So Sidonia, you may know more.
Well, I haven't had any direct client contact at this clinic. It looks like there is a sliding scale fee. So there's a fee for people who want to get psychological assessments, and those are usually at a more reduced rate than you would find in like other outpatient clinics or psychology clinics. And then there's fees for sessions, for therapy sessions as well. But those are also on a sliding scale fee. So like depends on income, things like that. I feel like I've seen some sessions cost like $25 for some therapy clients, which is definitely better than what you can find elsewhere. And I think there's a fee reduction form that you can complete as well if the fee that you're quoted is too high.
So I actually had a question. Maybe I don't know if this relates directly to your research or not, but about the prevalence of PTSD. I know in your examples you talked about, like a veteran who experienced combat and somebody in a car accident, and I feel like those are experiences that would pop into mind in terms of what might trigger PSD in certain people. But is it more prevalent than what we might think of as those kinds of extreme traumas, or?
Yeah, so if you consider just the definition of trauma and PTSD as I provided, we have an average of about 8% prevalence rate, according to the US in the US national sample. And then, of course, for certain occupations, it's more. So people who are in service, studies are different, but it could range from 12 to 19 to 20% I've seen. Again, this is all US data, but yeah, does it answer your question?
I assume you're not working with children.
I used to, but my area of research has been so primarily for adults. I just don't, and because I think also, since I do a lot of research, I don't feel like I have maybe I do have all the skills to work with kids, but there's a little bit of hesitancy. It's different. It's quite different to work with kids. Yeah. But did you have a specific question about that?
Do I have a specific question? No, I was thinking about, a lot of children experience trauma, particularly with child abuse or family violence, watching their parents being violent against each other. And again, like accidents and in war, I assume that a lot of the research that's taken place in this field with children is in countries with war.
Yeah.
I can add a little bit to that. So
Yeah.
I worked as a children's therapist before coming to UNT. So TF-CBT, which is trauma-focused CBT, is an evidence-based treatment for PTSD with kids. It has elements of the narrative in there, so learning to talk about the traumatic experience, learning to share your story. And this has been, I guess, has evidence in a variety of populations, not just war as well.
I know some people who suffer from generalized anxiety and panic attacks periodically. Could you talk a little bit about, where is the dividing line between something like that and PTSD?
Yeah, so that's a good question. So generalized anxiety disorder and panic disorder, they're just the different diagnoses than PTSD. So PTSD is very unique that it's always in response to a trauma and traumatic event. That you don't necessarily see with generalized anxiety disorder, panic disorder. Of course, there could be precipitating events and triggers, but it's not in response to a traumatic event. So that's the first thing. And then the second differentiation is the symptomatology. So generalized anxiety disorder is like, I would describe them as they're constantly worried all the time. Like there's no stopping point and it could be routine like things, like they'll wake up in the morning and they'll be like, oh, will I be able to get to work on time? Will I get my coffee on time? When I go to work, will this be on my desk? Will I be able to finish? And it's constantly worrying. It doesn't stop. And the proportion's a lot. It's in response to what it should be or compared to what it should be. So that's a generalized anxiety disorder presentation, which is very different from the PTSD symptomatology we just saw. Panic disorder is, when you get these bouts of panic attacks, and they can differ for different people, but sometimes it just feels it's out of nowhere, out of the blue, and then it peaks so rapidly. It starts with like maybe a shortness of breath, and then the next thing you know, you're feeling like chest pain, or you think you're going to die, and you're having nausea and vomiting and chills and cramps. So those are, again, there are episodes, and depending on how frequently they occur, they have to meet certain criteria, and that becomes a panic disorder. So they're all under PTSD was under anxiety disorders initially, and now they said, no, you deserve your own category. So they pushed it to a trauma and stressor related disorder, but they were all under this bigger umbrella first. Does that answer your question?
Yes, thank you.
Okay.
All right. Well, yeah, if there are no other questions, Dr. Contractor and Sidonia, we really appreciate you taking the time to present this to us. I think everybody found it very useful. And if there are any final comments or questions.
It's really good. Thank you so much.
Thank you very much. Good work.
Thank you. And
Really?
just before we disperse, I have a request. Since somebody talked about study recruitment, it triggered that in my head. We have 2 ongoing studies. Is there any way I can just send that information? If y'all know people, can y'all just pass it on? I don't know. Is that possible?
I think so. Lenora, I see you mouthing something, but I think if you
send it to Jordan.
Yeah, if you'll go ahead and send that information to me, I can pass it
Perfect.
on to all of our members.
Awesome. Yeah,
We can share that
whoever.
with the recording of this.
That'll be great. Okay, that was a good trigger for me. But thank you so much for taking this time. We really appreciate it. And you'll have my email address, and Sidonia, if you'll have any questions for us, feel free to reach out. But really, thank you.
Thank
It was
you.
really nice meeting you.
Thank you. I hope you all have a great afternoon.
Bye, everybody.
Bye.
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 Bye, everybody.